Ladies and gentlemen, welcome to Rooster AM. It's Ryan Nelson. Today on the podcast, we are joined by Jonathan Bushman, an Enid, Oklahoma native who is making waves in all of the right ways, whether it's through his work, his community involvement, or the way he shows up for people, especially when it comes to your health care. Jonathan brings a rare mix of integrity, insight, and heart. He's someone who isn't afraid to speak his mind, dig into the tough stuff, and he still keeps things real and grounded. So everyone today hopefully will understand what we're talking about. We're excited to have him with us today. So let's dive into this mind-bending conversation with Dr. Jonathan Bushman. And before we get started and start talking about healthcare, you may not know this, but we share an incredible connection that I discovered last night.
Interesting.
Yeah. So your grandparents, Gerald and Joan Bushman. All right. You might bring health care, but your grandparents brought something really powerful to my life. They were my parents' pastor when they were in Syracuse. And why this is important is because when I was born a still blue baby with an umbilical cord wrapped around my neck. Choked me out. So when I came out, I was not breathing. And my mom almost died at birth. Well, it was your grandparents who came to the hospital. They woke up the town, fell on their knees, and they prayed and prayed for my life and my mother's life. I was expected to have a level of brain damage, which honestly, some people might debate today. But by the grace of God, all those prayers were answered. And the damage to me was limited. I mean, unless I'm just unaware and people aren't telling me. But I think I turned out okay. And I just want you to know your grandparents played a massive role in my life and my parents' life. And I didn't realize this until last night. I was sitting there with my parents and they were like, "So who are you talking to?" And when I told them your name, wait, but is his dad or grandpa used to be a pastor? And I was like, I don't know. I'll ask him. And you told me as you were walking in, and that's pretty incredible. So they were in the healthcare business too. They were just in a different kind. So it must be genetic. Um, but to just get going so people can get to know who you are, what actually got you into the healthcare profession? Or if you have any statements about your grandparents, you're welcome to do that as well.
Yeah. Initially, I was inspired by a chiropractor when I was like 12 years old, maybe. I had a baseball teammate whose dad was a chiropractor, and he'd come and do adjustments during the day, and right before games, he'd come and crack her back and neck and everything. And I loved it. I was kind of in love with that idea of manipulation and chiropractic care. And for the next, I would say, 4 or 5 years of my life, that's really where my vision was. That's where I thought I was headed, is chiropractic medicine. And I had grown up with a DO in Alva, osteopathic physician in Alva as my family doctor, and then in high school met another osteopathic family physician, and basically got a little more experience to see that these guys were doctors and they did manipulation. I'm like, this is the best of both worlds. And as a 16-year-old baseball player out in Woodward, was playing for the Woodward Travelers at the time, and our pitching coach was a neurosurgeon that on his weekends and time away, he would come and he would coach the pitchers. I was a catcher. So we got to know each other really, really well. And over the time of that summer, getting to speak with him, getting to understand a little bit more about where he came from. He'd grown up in Shattuck, another small town, and made this whole career. And I thought, man, I haven't really thought about the walls outside of my hometown, right? And so I remember one night, I approached him in the clubhouse after a game and I said, "Hey Doc, I think I want to be a doctor one day, and I'm just curious what should I be doing? Like what can I do to get prepared to go to medical school?" And the first thing he said to me was like, just one of those things you don't forget. He's like, "I can't imagine a better physician than you. I just can't." And I'm 16 years old. I mean, number one, I don't believe in myself. Like, I don't know I can do this, right? And he says, not only can you do this, he's like, you'd be the best one ever.
That's like the encouragement you need
That's
before
what we
going
need.
in.
Absolutely. As a 16-year-old, when you're like, I don't know if I could do this, whether it's a financial barrier or academic barrier, whatever it is, I don't know if this is a doable thing. Is this even a possibility? Is what I'm asking him. And he was like, not only is it a possibility, yes, you'd be the best. And fast forward a couple of years, I get into school. I'm down in Edmond at UCO, pre med, and I called him up in early September on a Thursday. His CPA who ran their practice called me on Friday, and I started a job on Monday and worked there all through college. Did just about everything in that office, and I kind of laugh about it now. But the $7 an hour I got paid then was the best $7 anybody could ever be paid per hour to learn the things that I did,
Right.
to prepare me for school and to prepare me for life ultimately in independent practice. Uh, Kind of a cool story about that gentleman. His name is Butch Shane Halls, or as anyone ever played around or with him, he was just Doc, right? He was Doc Shane Halls, and he not too long ago came to me and said, "Hey, I've never really wanted to think about my own health, but it's about time I do, and I'm concerned." And he had a concern to share with me, and we sat on my back porch. He drove up from Oklahoma City, sat on my back porch, told me his concerns, and said, "I'd be honored if you would take care of me." I thought, wow, like full circle there.
Yeah, that's wild.
And actually had an opportunity to do a home visit last week. He actually recently suffered a minor stroke, and set him back in ways he's not happy about, especially as a neurosurgeon. You don't like to be uh, human for a while. And went into his home and had a medical student with me, and just some of the kindest words he speaks to the medical students, saying, "This guy right here is an all-star." He's like, "I've never had one better." He's like, "I knew it when he was 16, and here he is taking care of me." And that's been 25 years ago. So pretty neat, kind of full circle with him. And he really did inspire me. He uh, let me into their practice, let me into his personal life, let me into his professional life. The things that I learned, not just from him, but his entire group of independent doctors, was really the foundation of some of the beliefs and some of the directions I've taken later on in my career.
Yeah, which some of that's what we're going to probably talk about
Yeah.
here in just a minute. Um, can you explain direct primary care for those who are not familiar with it? Just an explanation of what that
Sure.
actually is.
Sure. Direct primary care is a membership based model of payment for primary care. So rather than charging a certain fee for every certain type of service that we provide, which is what we generally think of as fee for service, that's traditional mainstream primary care. Instead, we charge a monthly fixed rate, which provides all access to the patients.
Well, that's kind of what you do.
That's what I do.
Right, right.
Right.
So when you were in college, you wrote a 50-page paper
Mm-hmm.
about the rising cost of healthcare.
Mm-hmm.
How much of that rings today, and how much of that motivated you in that paper?
So, well, what it does is it shows you that for a long time my head's been wrapped up in this space, like knowing that the system isn't designed well, and there's a lot of responsible parties for healthcare being the way it is today. At that time, I was a college senior, was finishing up my major was in political science as I was doing pre med, and that was my capstone paper, and spent a full semester researching on all these variable um, attributions to the cost, right? And what you didn't say was what, and I'm not sure you know this, but the subtitle of that was shifting the responsibility.
Yeah.
And looking back, I was 100% wrong. So in every argument, whether it was the insurance, it was the pharmacy benefit manager, it was the hospital system, it was the, you name it, I had many different parties that I said had responsibility in this. Ultimately, my push at that point was, let's shift the responsibility. It has to be on the individual. They have to take charge, which on one hand I would tell you is very true.
Yeah, there's a whole other hand of
But
that.
But as we know now, and as I know now, as I've practiced for about 15 years and have seen the barriers to access or the barriers to care, whether it's financial, social, you name it, there's what we call social drivers of health. We used to call it social determinants. They're now calling it social drivers, which is probably a better way of saying it. This is what's driving healthcare. And honestly, physicians account, the actual care that we provide accounts for about 10 to 20% of a person's overall health. That's not a lot.
Yeah.
So it's a little bit humbling fact as a physician to hear that, but it's very true. So there's a lot of things that go into that. But yeah, shifting the responsibility now, I would say as I've matured in it and understood the various third parties that play a role in healthcare, um, I don't feel quite the same. I feel like maybe the patient being the beneficiary isn't always the beneficiary. They've
Right.
kind of become the benefactor of the system.
Well, when you look at like like insurance and care today, people face some serious obstacles when they go and they start to work inside of the insurance system.
Mm-hmm.
What do you think some of the biggest ones are? Because I have my idea of what some of the biggest problems are, but what for you as a doctor looking in, what's the obstacle that they have? Certainly the financial ones.
They are financial, but let's start with the most basic piece of the financial troubles in healthcare: prices. That's it. Um, we know that any restaurant, any grocery store, any major uh, piece of our market, you can easily access a price for a good or a service. That's how we exchange everything,
Right.
whether we're talking in the stocks or we're talking lunch, right? You have a particular piece of good or service for a particular price, and that's how we gauge it. And that's a free market. It's a capitalistic free market. In healthcare,
It's not that way,
good
though.
luck. Good luck knowing the prices. And not only that, we've added in extra complexity to that, which means in twofold. One is the price that your insurance pays for the same service as mine may be different.
Right.
But really, the only thing I care about is what my out of pocket responsibility is, which has further shielded us from the total cost because all we care about is the copay, the coinsurance, the deductible, right? What about the total cost of care? Has anybody started there and said, I think the total cost of what you're charging is not fair? I don't think that's right.
I disputed a bill, and well, I didn't. My mother-in-law did. She works for insurance companies.
Mm-hmm.
She worked for an insurance company, so she gets it. She took the bill and she went to the hospital first, disputed the bill with the hospital, then went to the insurance company, disputed the bill again. And when it was all said and done, my bill dropped from, I believe, like 5,000 down to 2,500. And I was like, I would have had no idea, like, to do that. When she looked at the bill, she was like, yeah, we need to go talk to these guys. I was like, why? She was like, because this is not right.
Mm-hmm.
What they're doing here is just not right. And so, um, when we walk into the insurance world, it's different when it comes to an exchange with, for instance, like house insurance or car insurance. Um, there's a difference between like paying for a risk versus paying for care.
Mm-hmm.
How much of it are we paying for risk over care?
Tons of it, 80% of it.
And do you think it needs to be paid
Paid is different than
or
covered.
covered? Yeah, do you think it needs to be covered?
No.
This
Depends
is
on what
why
we're
you're
talking
here.
about.
This is
Yes.
why you're here.
No,
So let's.
why are we covering through a risk product? That's what insurance is. It's a risk product, risk management product. At what point in time did primary care or your basic healthcare needs become undefined risks or potentially catastrophic risks? There's not a single evidence of catastrophic claims in primary care.
So what's the difference between a DPC model?
The primary difference is we lead with pricing, we lead with transparency. Um, Downstream, then we provide medications and labs at wholesale cost. In other words, we're not putting a margin on everything we're doing.
Mhm.
Our basis for revenue and our basis for earning a living is through memberships, it's through patients. And by receiving those payments directly from the patient, we've essentially aligned our responsibilities and accountabilities to the people that the system was intended for, which is patients. And we don't have a third party in entering that conversation of payment. So I'm not looking to a third party to ask them, how do I get paid to take care of this person that you represent? I'm just representing the person that just paid me. And that's why they call it direct primary care. It's a direct relationship. But the reason it works, the reason we care about it so much is that, again, I say this all the time, we're not anti hospital, we're not anti insurance, we're pro patient. But how do you become pro patient? You have to eliminate the parties or the things that might get in the way of you and the patient's relationship.
Right.
And the quote unquote payers in the system, which is really patients, employers, patients, taxpayers, but the payers, they like to call themselves, in Blue Cross, United, Cigna, Aetna, they inject different mechanisms, different formulas for how you get paid based on coding, based on incentives. And that's where it really gets messy.
Yeah, the coding drives me nuts because, like, the idea that, first, I think healthcare shouldn't be treated like an insurance. It should be treated more like a solution. Like that's where that's what you're trying. What's the solution to my health needs? Not what is it that my coverage covers, because you really don't actually know. Like, yes, you can, but the average human being can't just pick up the little CPT codes, all the jargon that they have on websites, and they say, read this. This is covering. This is the cost. This is your. I'm gonna be real. I'm not an idiot, but when I read it, I feel like an idiot. I'm like, I don't know what. And they're like, yeah, you can figure it out. Is this really a trick? I mean, or is it a trick just to keep us blinded, or is it truly just they just is it hubris?
It's complex. It's complex on purpose.
Okay, so it is purposely done.
Yeah,
Okay, so I'm not
absolutely.
all right because I was like, I'm not seeing through.
I actually just foundationally believe that people and even institutions' intents for things are pretty good. Like, I think they start in a place of good intention, especially when you get groups of people working together. Um, that intentions can start with the right ideas, right?
Right.
It's a matter of getting those intentions to translate down through the ranks, and especially when you're transferring money from one party to the next. And that's the trouble in healthcare when monies are transferred in multiple different parties. Each party gets to set a different gets to put out a different set of rules for how the monies get exchanged. And so, even if you create the incentive at the top or have a good intention at the top, by the time it gets down to the exam room between doctor and patient, that incentive often is lost. I had this conversation with the legislature actually over the Enhanced Medicaid Act here 2 or 3 years ago, and what they were doing at the time was, when I say enhanced, I meant expansion, Medicaid expansion, and I'm at the table with Oklahoma Hospital Association. I was representing the Oklahoma Osteopathic Association at the time. Oklahoma State Medical Association was there. Members of OHCA, which is the state Medicaid system, were there, and members of the House and the Senate. And we're in a chamber, a conference room at the Capitol. And I'm usually in those types of meetings fairly quiet until I know that I know what it is I want to say. And I was that day. Unlike every other day, I was that way. I waited, and finally, the representative conducting the meeting, I raised my hand and I said, "Here's my concern. I'm listening to all parties at the table, and I think we're all here for the same reason. I think we're all here to try to better the health care of Oklahomans. I think we're all at the same table for that. What my concern is that everything that you've just said as your intents of this bill, I would 100% back you. I would support this all day long because the intentions of what you're trying to create are wholesome, and I think they are meant to help people. My concern, however, is because I've actually seen this and felt this firsthand as a physician, is that You're receiving monies from the federal government with rules. You take it from the state and you give it to hospital systems or health systems by another set of rules. Those systems then contract with their providers and pay them in other ways. And sometimes the incentives that you've created, wholesome as they may be, the intent of this bill is great. I lack faith in the additional organizations that are taking your monies to see to it that those incentives actually come true at the exam room level.
There's a
And he looks at me, he's like, "Where have you been?" And I'm like, "I don't think you can legislate this. You can legislate the bill, but you can't legislate an incentive that stays true through the entire process because the monies have been exchanged, and once they're out of your hands, you can't do anything with it."
and there's greed.
Of course.
There's greed built into it all the way down. I mean, you think about um, the and I'm not calling anyone out, so that's
Sure.
not my intention. But I know that there have been times where I've been with a doctor who said, "Hey, this is what you need. This is what you need to get." I go down to the pharmacy. They say, "Well, this is how much you can this is how much you'll be covered." And there was the time where they were like, "Yeah, it's going to be this $20 whatever your copay, but then you're going to have to pay like 130, $200 up to you get near deductible." And I was just sitting there looking at all this, and then I was looking over, and there was a little sign, and it said clever, or like RX, something clever RX or something. Type it in. I typed it in. I was getting the same. I could get the same medication just by showing them the coupon for like it was like 20, $30. I could buy a whole year's supply, and they were like, "Well, you won't have to pay after you get your third bottle." And I was like, "Or I could just use this." Is that because there's the money changing hands all the way down, and they keep increasing price and increasing price, or is there just a there is no, or is it the Wild West and you can price it whatever you want?
No, you know what?
Like,
This is going to sound crazy to you, but especially for our local pharmacies, I'll back them all day. Um, the crazy thing is, and you mentioned Clover or Clever, it could have been Good
yeah,
RX.
good
Good
RX,
RX is
yeah.
a really common one. And this is a whole nother, like, you could speak for hours about this problem, but that problem you're identifying is a pharmacy benefit manager. This is one extra third party that probably never needed to exist, but it has for obviously most of healthcare's transactional needs. It's been there, um, but PBMs actually make this incredibly complex for pharmacies. And what wouldn't make sense to the average consumer is that when you go and get a prescription from the pharmacy, you have no idea the access cost for the prescription itself for the pharmacy. You have no idea how much they paid for it in the first place, nor what they're getting paid by the third party to dispense it. There are cases, and some people this would ring true for them when they've had their pharmacist tell them, "We don't sell that here anymore." "What do you mean you don't sell that? It's a brand name medication. It's everywhere else. We don't sell it here anymore." Why? Because, particularly for the small pharmacies, their ability to acquire the medication at a reasonable cost and then actually get paid the full value of what they just paid, they're actually literally losing money when they sell it because the third party pharmacy benefit manager is paying less than the cost of the acquisition of the drug itself. Now, your large pharmacies, Walmart, CVS, Walgreens, they buy in such bulk that this doesn't become an issue for them. But it's also part of the problem because they're all associated with the largest pharmacy benefit managers, which are also associated with the largest carrier insurance companies.
Wow. So what would be, and that's a little different than the primary care with the cost of the pharmaceutical stuff. It's just, I found it odd that my insurance would say we'd cover this much, that much. And then you would go look at the insurance plan, and then you could find, for instance, you can find the same stuff in, all right, again, I don't know if this is right or wrong. Plus, you're buying overseas, Mexico. You can have something sent from Mexico.
Mm-hmm.
It'll cost pennies compared to what it is here. Is that an insurance thing or a pharmaceutical thing,
Yes.
or both? Was that a
Yes.
yes, both? Okay.
Yes. I mean,
So is that
they're
what's
interrelated.
driving the costs up, or
Yeah, but more so the insurance. So sometimes the pharmaceutical companies themselves, the acquisition cost, the actual cost of producing those goods isn't very high. The manufacturers don't actually have super high prices in a lot of cases. But when people have, you know, the specific ability to acquire those medications and reprice them or resell them, that's where some of this gets a little messy. Um, I'll give you an example. Speaking of Mexico, actually, beginning of my direct primary care practice, I had a Mexican national that was engaged to a Mexican American immigrant, and of course didn't have any benefits in the United States. And unfortunately, she had what's called chronic lymphocytic leukemia, and she had to take a daily medication, basically to preserve her life and her health. And yeah, so this medication is known as imatinib. It's a generic imatinib. Brand name was Gleevec. And at the time that they came and established care with me, her husband was telling me that since she's been in the United States for the last 3 months, that he'd had to go to Mexico or get medications from Mexico, and it was costing them 2,000 US dollars monthly to get
to get it from Mexico?
from Mexico.
How much was it cost? What it cost
About
you?
5,000 a month. Again, brand name. That's the insurance price. He's telling me about this, and I said, "Well, just give me a moment. Let me see if I can acquire it. Let me see if I can get it through a wholesale distributor." Within 3 minutes, I had it ordered for him, less than $300 a month. Less than $300 a month.
And is that because of the way you have it set up?
That's because I was ordering directly through a wholesaler that's getting, direct from manufacturer at the low
Skipping
rates.
all the third parties,
Exactly.
skipping the hospital, the doctor, all of the.
Exactly. And this
And
is kind
how
of
can we do that, or does the doctor have to do that?
Yeah, you have to be a licensed professional to be able to even order them.
Really? Okay.
You have to be a pharmacist or a licensed professional. Yeah, interesting story about that too. I shared. So of course, as I'm telling him this, he's like, he's tearing up. He's really having a hard time. Like, are you real? Like, are you serious? Mm-hmm. I said, yeah. I mean, this is a $21,000 a year savings I just found for them, for her, the preservation of her life, right?
Yeah.
And to see him try to interpret that to her, holding his composure, and as she's starting to hear it and break down, was just like,
He's probably shaking in shock.
oh, he was absolutely.
Yeah.
And I'm losing it too. Like, I'm trying to keep myself together. Like, this is incredible. And I'm telling this story. This is halfway sad part of the story, but it highlights something. A week or two later, I saw a pharmaceutical rep that I had known for years, and honestly, great reputation, great man. And I really, really liked the guy. So I tell him this story. I was like, "Hey, check this out. Look what I did. So fun. Like, this is the coolest thing I've had a chance to do so far." And I tell him the story, and he's like, "So how much do you sell it for?" And I was like, "What do you mean?" I was like, $300. That's what I had to pay to get it.
Yeah.
And he's like, "I know, but you could have sold it for $1,000, and you're still their hero." And I was dumbfounded. Number one, I said,
Well, was he a pharmaceutical rep?
Yeah, yeah.
Okay.
And I was like,
yeah, he probably views it a lot.
That never even crossed my mind. It never crossed my mind. And secondly, as much as I like you, there's a reason I do what I do, and there's a reason you do what you do. Mm-hmm. And I'm glad to be on this side. And I don't mean that to be rude, but I'm glad I'm on this side.
Pharmaceutical reps in it for profit. And a doctor, okay, and I might be slamming doctors, and I'm not meaning to just like hold you up in the air like you're the golden child, but the doctor's supposed to care for the patient first. That should be the number one care. And that should come not just with the health, but also financial care. Mm-hmm. To understand that, like, some people just haven't been given the great lot in life. I'll tell you, I've been a pastor, so I've seen some people just have just disaster after disaster. Mm-hmm. It's out of their control. Mm-hmm. Should we still care about them? Yes, I think there is a model to where we have to care, That sounds like kind of what you were doing for this. But I didn't care about the money. I cared about these two people and her being able to live a life and them not live in financial ruin. I mean, I can't imagine $2,000 a month for a medication to keep your wife alive.
Mm-hmm.
Yeah, I would do it. I mean, I would do that to keep my wife alive. But man, if someone came up to me and said, yeah, it can really be 300.
Mm-hmm.
Like Mexico was jacking the price up.
Mm-hmm.
That's insane.
Mm-hmm. And listen,
That's
I say this
insane.
all the time, and at this point, I work with a lot of people, even outside of my practice. So I'm working with business owners, um, or hospitals, third party administrators, even pharmacy benefit managers. The good ones, I work with them, the transparent ones. But here's the thing.
Wait, so hold on. I know you're going somewhere, but I can't lose this. So
Yeah,
you could have legally just charged whatever you wanted.
absolutely.
So okay, so they put regulation on stuff all the time, but they don't put it on medication. Like there is no regulate. You could sell it for whatever you wanted. Like someone could be dying desperately, and you could say 20 grand
Mm-hmm.
to save your life,
Mm-hmm.
but it really could cost you $20,
Sure.
and no one's there to say you're wrong. There's
Well,
like no
wrong from
moral.
what standpoint?
There's no
Moral
moral. Yeah,
standpoint?
there's
Ethical
no.
standpoint?
Yeah,
I don't know. What
that's.
about the homeless walking by the restaurant and the restaurant doesn't offer them reduced or free food?
I don't get it. Honestly, I say
What I
fair
mean,
game.
what if the restaurant prices were 10 times higher than they were?
Well, it's different because that's a
It is different.
luxury. This is your life. Like that's a huge difference. It's like saying, well, a Corvette versus a used 1995 Blazer. Like well, that would probably be pretty expensive, but you know what I'm saying. Like that's different than just we're gonna up this price because we can,
Mm-hmm.
not because what it's worth,
Oh, well.
or is the worth
And
based on how desperate
I
you
don't want to
are.
lose you on a rabbit trail, but we all know that GLP-1s for weight loss are incredibly common and incredibly popular right now. Honestly, they work great. People have great results from them. Do you have any idea? And by the way, this comes out of Yale University. Do you have any idea what the raw cost of the ingredients for the GLP-1 peptide is?
I'll take a guess. $20.
A quarter of that. Less than $5 for a month's supply of a GLP-1. That's what the raw product is.
So why is
Where
it so expensive? Just because they say this is what people are willing to pay?
they're willing to pay it. The FDA's approved it. It's a branded medication. We've got research and uh, research dollars behind it, all kinds of things behind it. And so it's justifiable in the sense of this is what we have invested in it. However, it's a peptide. There's nothing really that special about it. It's a peptide.
And that's the weight loss,
But this
right?
isn't.
That's
Yeah,
the weight.
yeah. But this is just an example of like the raw ingredients of what we're using for
But
medications are so
how
cheap.
much money would the insurance company save if they said, okay, first off, America's pretty obese.
Mhm.
If they gave us a preventative for all the other stuff they'd save money on, wouldn't they want to do that?
Yeah. No, we're getting into like whew, really big, wide topics.
Okay, sorry. Yeah,
And
I'm
no
just
pun intended, but
yeah.
like really, we are. It's
Well, I'm
such
someone
a
who's just
deep.
I've been lost in this forever. That's why it's interesting to me because it just I don't understand it. Like I just don't understand how things start like that. So it's this much, and we're just going to keep upping the price until we get to a point where we say this is what people are willing to pay. Don't worry about people who can't afford it
Mhm.
because we're going to make more money by selling less at a higher price. Then we don't have to manufacture as much. It almost comes across evil to me when you have the ability to go out and save people and to prevent their lives from being ruined. And you're like, yeah, but I'll only do it for a price. Oh man, there's just something to me. It's just I can't believe there's not regulation on this stuff. They'll regulate a gas can
Mhm.
because they're afraid it's going to explode. That happens once, and they spend millions of dollars. I mean, there's a company like right in Oklahoma. I don't know if you know this about the company. It was that they made the gas cans and they manufactured like 100,000 of them. Well, after they did, This was back in the 80s. Congress passed a law saying, well, now you have to put do not swallow on the can. Well, they had to go back. Well, it was metal. They couldn't go back and put it back on it after they'd done it, and it bankrupted them, and they went out of business. And then another company magically appeared and took over, which was probably supported by. But you look at that and you think they're willing to regulate a gas can because like one baby drank out of it, but they're not going to regulate medicine to save millions and millions of lives. Now, I'm conservative through and through, and I believe in the free market. But I also believe that there is an ethical line that you have to draw somewhere. I think you're doing it in a way with the way that if I'm gathering this right, you're removing costs by them just coming directly to you. You can remove those costs.
It's bigger than that, but yes.
Yeah. Why is it that everyone doesn't do that?
Because they have different revenue models. There's different places for them to create a value of sorts. So if I'm a third party that has nothing to do with the actual provision of care, and I'm also not providing the risk tool, I'm not the insurance, but I find my place in medicine, I have to make a margin. And it's through acquisition and sale, acquisition and sale, acquisition and sale.
There's got to be a profit for you.
But is it necessary? Is that third party necessary? Could it be done without them? And the answer to that question in many cases is yes. The other trouble, and just talking big picture here without getting too deep, is healthcare represents about a $5 trillion industry with an estimated 30% fraud, waste, and abuse. So the estimate by CBO is that $1.5 trillion a year is for fraud, waste, and abuse in healthcare.
And we're paying for it.
We're all paying for it.
Yeah.
And don't think that you're not paying for it. Even if you don't pay for your insurance, you're paying for it. If you earn a wage and have a tax, you're paying for it. You're paying for it. We're all paying for it.
That's sickening.
And if you're not paying for it financially, you're paying for it in your health.
Yeah. Wow.
Mm-hmm.
A third of healthcare is waste.
Fraud, waste, and abuse.
And I mean, you can't save that, but you can avoid some of it, correct? By cutting out third parties, because there's probably a lot of fraud in that third party.
Who is you in this case? Are you talking me as a physician?
I'm talking you as a physician. I know you can't save the
because
world,
patients
but
don't know where that is, and that's kind of the problem.
Do you know where it's at?
Some of it, yeah.
Really?
Yeah.
Are you okay with saying where it comes
no,
from?
I mean, a lot of it is actually there's actually a lot of it in within the care providers itself, the hospitals, the physicians, the groups. There's a lot of billing that's happening that's not necessary. It's just not necessary. But now, do I think that the hospital systems or health systems and physicians and providers in the system, do I think they're the main party? No, not at all. But there are some certain incentives and oftentimes billing incentives that create some business practices that aren't healthy and questionable at best at times.
But most hospitals, and I read this a long time. It might be different now after all the government intervention. I doubt it, because anytime the government gets involved, it really doesn't help very much. Was that aren't most hospitals, they lose money every year?
Okay.
Or is that on paper that they lose money?
Totally depends.
Really?
Totally depends. And I don't want to be a speculator, so I won't dive too deep into that. But there's a lot of really interesting ways of corporate accounting that I've recognized, and I'm definitely not a conspiracy theorist, nothing like that. But there are times where what is shown on paper and what's the reality of the organization in terms of its financial health, very different. And that just depends. We've got for-profit health systems, we've got not-for-profit health systems. Most people hear those terms and think that the for-profit systems are likely the ones that are the culprits. In many cases, it's the not-for-profit health systems that are even worse culprits. Marty McCary, who happens to be a physician, pancreatic biliary surgeon from Johns Hopkins, he's actually the head of the FDA right now. I don't know if anybody knows that, but Marty McCary, fantastic doctor, great author, speaks out. You'll see him on the news stations frequently, even before his time at the FDA. Dr. McCary wrote a book, has written several books, but his second of which was called The Price We Pay. Phenomenal book for anyone interested in the consumer side of healthcare and what's broken and why, and what the parties are that's helping to create that. That book is a really, really good example as he tells stories across the nation of his research. Graduate students and research from Johns Hopkins are digging into the details of billing practices of different health systems. And he has some phenomenal stories and unfortunately true stories of how the system has really, really wrecked communities, families, all primarily around the billing practices. And again, the further, this is just my, as a physician, it's easy for me to say this, but I truly, truly believe it. I think the further removed you are from the exam room versus, in other words, the eye to eye contact with a patient, I think the further removed you are from that, the less likely you are to be able to hold to the principles of which healthcare we're intended to be. It's that direct accountability that you have. We can go into it further, but I've been doing health benefits as well for a few years now, and created one of the only physician-owned agencies. And while I haven't promoted it a tremendous amount, I still have a lot of good business, and I've got a lot of good headway going with that. But I have a business partner in that, and when we got together and we said, "Are we better together or separate, just working alongside each other?" The idea there was, I want his help. I don't ever want to be alone in this. I always want that other voice to keep me accountable. But I think the physician voice in the benefits discussion is essential because we're the only ones who've ever been in that exam room looking a patient face to face, trying to advocate for their health and their financial health. We're the only ones who understand that. And you've got businesses making multi-million dollar decisions on their health plan with people who've never stepped inside of an exam room other than being a patient.
Yeah.
It's different. It's different. It's
It's
different
also,
when you know what needs to be done, or you know what somebody needs and you can't get it for them, or they can't afford it, or their health plan wasn't designed around that.
you see a broken
It's
heart.
really, really hard. Oh yeah,
When you see,
it's a barrier for us.
yeah, when you see a broken heart, you're like, okay, I can either do something or make money.
Mm-hmm.
I I understand. I'll be real. Donald Trump came into my office and he was like, "Hey, I need this, this, and this." I'd be like, "I'll charge him whatever I'm going to charge." Right. But there are people who come in that they just can't. They don't have it, it's heartbreaking. And I mean, I've heard the stories. I've helped people. My phone keeps going off, and I thought I turned it off. I've helped people before, like from a pastoral side, and they come in and they're like, "Here's my bill." And when I read the bill, will a negotiator call the hospital and just say, "Hey, it's a hardship." Sometimes, if you're a pastor and you call, it kind of helps. I don't know why, but it does because when they call, they're like, "Nope, nope, nope." But when I call, they would listen a little bit. But they would say things like, "Yeah, it's a $6,000 bill. So if he pays 2,000 today, we'll call it even. But if he waits till next week, we can't do it anymore." Why? That sounds to me like a classic car salesman fear tactic. If you don't figure out a way to get $2,000 in the next 2 weeks, you're going to have to pay the full bill. Why wouldn't you just have them pay the full bill if they had to? And why are you willing to drop it down to two? Like, we're willing to pay the fair wage. Why is it that so easy to do that? But then to turn around and put a gun to their head saying, "Figure it out in a week." It's almost like a heist movie. It's like, you've got 1 week to give me my money or this. You got 1 week to give me 2,000, or we're going to charge you 6 or 10, and we're going to just ruin your life. So then they go around and they're calling me. They're like, "Pastor, I'm trying to sell some stuff to just." I'm like, "Whoa, whoa, 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 settle down. Like, what are we doing?" I would normally try to raise the money for them so they could pay their bill. But I just think it's wild how heartless that system can be. Now, I'm going to ask a question, and again, I can always remove the question later. Um, how much of your, I mean, I'm assuming, are you a man of faith?
Mhm.
How much of your faith influences your practice, and how much do you prioritize people over profit? Because I see that, I've heard that when you were talking about the lady that went to Mexico to get her stuff. That actually sounds a lot like what Jesus would do. How much of that impacts your practice?
So for sure, it impacts my practice even from the get go of why I'm doing what I'm doing. I mean, that's why I wanted to get into medicine, was to help people. I didn't realize, and I'd love to come back and comment a little bit about my grandparents' relation to your life and mine as well. Um, but it's interesting how much, as I got into the actual care after kind of toward the end of medical school and into residency, and really into practice when I got to know patients on a deeper level, that the lines between healthcare and ministry are very, very faint. We're working in many ways around the same problems. We are looking for solutions with the same groups of people. And where a minister finds himself at the head or the leadership of a church, a group of people, a patient panel, or your group of patients, while you know them all individually, you kind of think of them like,
They're your children.
these are the people I'm here to take care of. These are the ones I protect, right? Um, One of the reasons I got out of the initial fee for service world and went into direct primary care was that there were too many times where my mind actually started working towards the billing revenue earnings portion of it.
Mm-hmm.
And it wasn't something I saw coming. But then it was like, it just doesn't feel good. This doesn't feel right. When I realized that caused me to look at a patient differently, good or bad, right? Good or bad. Um, Whereas in direct primary care, it really was, okay, my whole intent is to have you as a patient. And because it's a membership based prospective payment,
Yeah.
I don't care where we are. Hit me up at church, hit me up at the grocery store, hit me up at the convenience store. I've had people drive up into my drive. Okay, now that's not like the norm, but I've had people drive up in the drive and like, hey, I have an issue. I need you. Okay, all right, it's fine. I don't feel inconvenienced and I don't feel um, abused when people access me when they're members of the practice. I just don't.
Yeah.
And why? And it took me 2 or 3 years in direct primary care to figure that out. I felt it. I knew the difference. I couldn't really explain it. I didn't have the words for it. But the words for it really are, and I think of this too, like, if you're talking about faith and ministry, yes, people are in front of you for the sermon or that week's, service.
Right.
That doesn't mean that you're unaccountable to them for the rest of the week.
Oh, that's true.
Right.
Yeah.
But unfortunately, in healthcare, it's so transactional, particularly in the fee for service model. It's a transaction, right? And if someone hits you up after hours on the weekend, always seems to be calling after 5 because they forgot to call earlier, right? It's not that. They're avoiding the transaction. It's the, I don't want to wait on the phone. I don't want to wait for an appointment. I don't want to pay a copay. I don't want to do these things that are so transactional. I just need something from you without feeling like I'm going to get billed. But on the other hand, we as physicians feel, in those cases, feel abused. You didn't take the time to call me during office hours. You didn't do this. You didn't do this. You didn't do this. But come 5 o'clock, you're willing to call. You're willing to stop me when I'm with my family. You're willing to do all these things. And funny enough, a lot of people that I talk to, my colleagues, when they're looking at potentially going the route of direct primary care, they'll ask me, "So you're on call 24/7?" I was like, "I mean, we share call now too. Yes, we're on call a lot." Or do you not just get abused? I'm like, nope, not at all. And you know what? When I do get called after hours or see somebody, um, outside the clinic. Not a single ounce of abuse. Doesn't feel like it at all. The other thing is people aren't worried about being able to get in. And so because of that, we're not creating this barrier to access. So they're like, hey, I need to give you a call. I'll call your office in the morning. They don't even tell me what it's about, even though I'd be willing to listen. Like, oh, yeah, I need to call you. Okay, perfect.
That's how you would think it should just be, but it's not. Yeah. I had a, uh, yeah, you know what? I might just switch over to you. Um, so for instance, I, I had a doctor once tell me, I'm trying to do this without saying the name. So I said, I'm having an issue with this. This is pretty pricey. And she looked at me and she said, well, that's really not, that's not my thing. I don't have anything to do with that. That's going to be with billing and your insurance company. But what you just showed me is that's just not really true.
So don't think of me differently, but I would have said those same words 7 years ago.
Really?
Mm-hmm. And I did say the same words 7 years ago because in certain ways I was taught that way. That's not for you to be concerned about. You just make the recommendation for the patient. That's between them and the business,
Right.
right? The insurance, whatever. Yeah, I said that, and I'm ashamed to say that I said that. But the fact of the matter is, I didn't know. I didn't know where they could get a better deal. I didn't know how to do things for them. I didn't know what avenues to take to get them the what they needed, but to do it in a financially sound way. Um, and as many of my colleagues that do what I do could attest to, once you've seen certain things, you can't unsee them. Once you understand them, you can't not understand them.
Can
Right.
you give me an example?
Uh, the example you just gave of the medication. You
Okay.
can't look at a prescription that's ever sent to the pharmacy again without giving it second thought and going, is that really the cost of that med?
Got it.
Right?
Mm-hmm.
Or you hear somebody negotiated a bill from 6,000 to 2,000, you go, so when I get the bill in the mail for 6,000, is that the real bill? Is it negotiable? Well, why did we start at 6,000? I there was a time where I was under a self-pay model, a health share, which I'm actually a big fan of the health shares, but I was under a health share, had this large bill from an ER visit. Okay, I get the bill. The bill is for $1,762. $1,762 for just the physician portion of that bill. I knew that was too high. Okay, um, and it's sort of dangerous the information I can get really really quickly. So I go onto CMS.gov. I look up a physician fee schedule tool. Click on that. I call the billing company. I said, hey, I got this bill. It shows $1,762. Um, I was just calling to see if we can negotiate a lower amount as I'm self pay. And they said, well, we can give you a 20% discount. I said, okay, in all fairness, I think we have a problem with where we're starting. And when you're giving me a percentage off of the bill, that's a relative term. It's a percentage, it's relative to where we started. The problem is we started at a really, really high price. And I said, well, that's all we're allowed to do is a 20% discount. And I said, okay. I said, well, I have in front of me the CMS physician fee schedule, and it shows for that same code of service $172, which means you charged me 1,000% of Medicare. Did you know that at your hospital you average around 300% of Medicare on your commercial reimbursements? In other words, you're asking for 700% more than what Blue Cross or United or anyone else would do because I don't have an insurance.
Why am I getting angry?
Her response to me was, well, those are pre-negotiated rates. And I said, okay, well, this was an emergency situation. I didn't have time to pre-negotiate the rate before I received the care. Are you suggesting that the value of the care provided to me is 2.5 times greater or 10 times greater than Medicare because I didn't have the chance to pre-negotiate the rate? Did the value of the care change based upon who was paying? You know the answer to the question. She's like, I'm sorry, sir. All we can do is a 20% discount. I said, okay. May I speak to your manager? I would love to at least file a complaint or at least a request for something here. And I said, I'm willing to give you X amount of dollars. I don't remember what I said, but it was about 300% of Medicare. I'm willing to make that payment today if you will write off the rest of this. I'm sorry, sir, we can't do that. So, okay, can I speak to your manager? She said, she has the same rules I do, sir. And I said, that's okay. I'd still like to speak to her. So they get her on the line. I repeat what I just said to her. And she's like, I'm sorry, we don't have the ability to negotiate these. And I said, you do have the ability to negotiate them. It's just on the billing side after the fact, you're not allowed by your employer to do this. I understand this isn't your fault. I understand you didn't create the rules, and I understand that your job is to collect money. And you're looking at me as my job to pay the money. But what's being done is not right. And I have two options. I can either file a small claims case because we're under $3,000 and we can fight this, or you can negotiate with me. I'm sorry, sir. 20% discount is what we have. I said, okay, fair enough. Can you tell me what my balance is? She said, it looks like your balance is $1,752. And I said, okay. She said, it looks like a payment was made for $10 yesterday. And I said, perfect. That was me. I made a $10 payment yesterday. I've got on my schedule to pay you $10 for the next 172 months.
Yeah.
I'll have an active account that whole time. And if you'd like to negotiate, please give me a call back.
Did they call you back?
Yeah. And we settled for a few $100s.
There you go.
Yeah.
So they can negotiate. They just don't want to.
Yeah. They don't want to.
Yeah, and they say, well, we have rules that keep us from doing that. Yeah, but those
Yeah,
are rules
I-
within your employment, not.
Now, the interesting thing here is that the physician who took care of me is a colleague, a friend.
Mm.
And I had very friendly told him, like, hey, this is the bill I received. I know you don't like you're doing your job just like I do my job. I would willingly pay you cash for the service you did. And I want you to know that I gave you high reviews and that your care was excellent. Like, I have absolutely nothing bad to say. Do you understand that the party behind you is billing in this fashion? And furthermore, if they bill other people in this fashion, it makes me hesitate to send people to your ER. Like, this is concerning to me.
Yeah.
It makes me think twice about wanting to send people or what happens to them downstream when I do send them. And so,
Did he even understand the bill, like that, what they were doing? Or
he did, but he has no influence in it.
He's like, but it's not my deal. And I kind of understand that logic. Well, my deal is to figure out what's wrong with you. It's not mine to do all this.
Sure.
But I will say, doing all of that is part of their health. I mean, that guy who is paying $2,000, the amount of stress, anxiety put on his body and family over time, the damage being done mentally over a bill. I think that becomes part of the health issue.
Absolutely.
Is the financial side.
Well, and here's what we're talking about, but not recognizing in the conversation is that this is all after the fact.
Mhm.
The price that we can't put on paper is the price of health because of the price of healthcare. And what I mean by that is so many people avoid the system, avoid taking care of themselves or going to get care because of the fear of the cost.
That's a true statement.
And you cannot put a number on that. It is incredibly difficult. So one of the things in direct primary care, and again, we work with a lot of employers, and this is a really, really valuable thing to the employer, is that when my people need help, they need help. I don't want them to have a barrier to get into you. And that includes no copay. As members of our clinic, they get in. There's no money exchange at the front door. They're members, they walk in, they barely sit down there in a room. We're taking care of you. And to an employer who's already in paying plenty, to them, direct primary care becomes the investment they didn't even realize they needed. And once they've made it, when they see what happens with their employees, that their employees called that morning and got in that morning, or got in that afternoon, or they left the clock and were back within an hour, prescription in hand, problem solved, plan made, like that's just not, that's hard to replace. But it's the barrier to care, which is often financial, that costs people their lives.
It's my dad. My dad got
because they
lymphoma, and he was about to refuse the chemo because he was like, I don't want to pay all of that. And my dad, a little dramatic. I'm worth more insurance dead than I am alive to my family.
Mhm.
And he's older. He's in his 70s. That was his. I'm
Mhm.
not going to do it. And I'm like, it was my wife, or my wife was the one that basically said, if you don't, you're selfish. You know, and just went on him. You know,
Mhm.
my wife doesn't get very upset. She was mad that day,
Mhm.
and so he did, and it ended up costing, but it wasn't. I mean, it was a few $1,000s when it was all. But I mean, that scared him. Just the idea of it scared him to not want to go in. And I'm like, this is life or death, Dad.
Mhm.
And you're willing to just take the out because you don't want to, because you're scared of the bill.
Mhm.
That's
Well, and what we're seeing now, and I've this has been through multiple conversations with multiple ER physicians, colleagues, and friends of mine. Um, what we've seen post COVID, even as prices have gone up, it's a mess, right? But what we've seen in the ERs is actually, in some ways, less volume, in some ways, but the acuity of care is so much higher. And to us in healthcare, what that means is people are coming in sicker. They're waiting longer to get care, or they can't get into primary care, and they can't get into primary care, and they can't get into primary care, and then they end up in the ER, and their problems are far more severe than they could have been. And that's costly. It's costly to their health. It's costly to the system. It's costly to the resources of the system to take care of them. And we've seen a lot more of that. And it's really a travesty. And it's twofold. One is you've got ERs trying to take care of all the primary care needs that aren't being met at primary care. And if there's no real major penalty to go to the ER, the copay in the ER is not that much more than the primary care doc, then what's the rub financially? But secondly, the people who are really there that need the ER physicians, need the hospital, they're coming in sicker,
Mm.
which is devastating. And it's avoidable. Many of these things are avoidable, and I don't think people quite realize or recognize that the impact of the financial impact of the system isn't all just when it's consumed. It's the avoidance.
Yeah.
It's the avoidance of the system.
Yeah, that's because I'm the same way. I'm, well, what is that? It might go away in a week.
Mhm.
Hell, it might go away in another week. Why? Because I know I'm going to go in, I'm going to pay this, and I'm going to pay that.
Mhm.
My kid's got a football thing I've got to take care of. I know
Mhm.
I got to get him this new helmet that's like $700. You know, it's like,
Mhm.
all right, maybe this isn't a big deal. And you
Mhm.
just kind of push it off to the side. I did that. Went to the urologist, right?
Mhm.
I'll tell you, it's the worst story of all time. Everybody's telling me, Ryan, the urologist is not a big deal. It's not a big deal. Like you're making it more in your mind than what it really is.
Mhm.
I go in and they go to try to put a catheter in, and when they do, they hit some sort of flap that blocks it because it was already having some blockage.
Mhm.
Within 2 hours, I was on an emergency table. They were drilling. My worst nightmare came true, like in that
Mhm.
moment. But you know, the other thing is when you were talking about the pre-negotiated rate, is that what the insurance company? Is that what they were trying to say, or is that just with the insurance company, or is when you sign your little paper and you're going in?
Oh no, that's with the insurance company.
Okay, all right,
Yeah.
that's what I was thinking.
Yeah.
Because I'm like, I have, I don't, I had
It's
no room to negotiate that. It
no, no,
was,
no.
it was me
And
down on the table. Like,
if you really want to know the game is when people go, "Why are these bills so astronomical? This makes no sense. Why are you charging multiple hundreds of dollars when the insurance is going to pay 80? Doesn't make any sense."
right.
It's a game, and it's a game by primarily the commercial payers, Blue Cross, United, Cigna, Aetna. We call them the BUCAs, and it's a game by them because to gain market share, to sell more insurance products, they need to show you the value of their place in healthcare. And one of the ways they show that value is through the creation of networks. We've all heard of them. PPO networks, preferred provider organizations, networks, right?
Yeah.
And those network contracts, they contract with big health systems and small too. But those contracts are all based on a percentage of discount off of billed charges.
Okay.
Think about this. So let's say Cigna comes into the market and they boast 75% discounts on billed charges. Blue Cross comes in and says, we have 83% discount on billed charges. What's the real charge? What's the real value of the care? Well, we're not really worried about that. We're worried about the discounts because that's what makes us valuable and that's what sells insurance products to the larger market.
Their
We can give
ideas.
a better discount.
Yeah, this is what we're going to do for you.
Right.
But it's really just a marked up price.
But because of that, all the providers and health systems have to elevate their prices in order to account for these larger and larger discounts that the networks want. And it's a push and shove with where we end up and what's the actual, as we call it, the allowed amount. The allowed amount is the allowed contractual amount. That's the real payment.
So when they know what that is, that's what they go off of.
Right. But think about this for a moment. If prices were truly transparent, fixed, and not negotiated or not negotiable, what value does that insurance company have when it comes to market share?
Not as much.
Not as much.
Yeah, I mean, very
So
little.
it stays that way for a reason, right?
Wow.
So those contracts and those fee schedules and everything else are considered proprietary. Which, think about this: have we ever, like, again, I do employer health benefits, health plans, and advising for businesses on their health plans. What we've done, and it's a really asinine process, is what it is. What we've done is 90% of our healthcare is local. It means 90% of what we need for our healthcare needs can be delivered at the local level. We have the resources here. Okay, 90% of it. But what have we done? All the employers in town, what have we done? We've taken monies out of our revenue and out of our employees' paychecks, and we've sent them to a third party outside the community for them to reprice and tell us the value of the services provided by our local friends and neighbors and health systems. And whatever those negotiated amounts have been at the third party level are now considered proprietary. We've given them our money, allowed them to put a price tag on all the services, and allowed them to consider that proprietary information. And yet we pay for it. That's like going to a restaurant and saying, I don't need a bill, just tell me what I owe. Don't tell me what I ordered. Don't tell me the cost per unit. Don't tell me the tax. No, I don't need any of that. I just need to know how much is it. And by the way, it's proprietary. Here's my money. Please do a good service for me.
This makes me feel dirty.
Well, it is.
Like it literally makes me feel dirty inside knowing that
But
I'm a part of it by paying in.
there's a better way.
Right.
Okay.
Yeah.
So I will say there's a better way. And again, I've already referenced it, but like college, I was already in this headspace. So my first job, that $7 an hour, was filing claims. That was my first job. So I saw all the codes, I saw the billed charges, I saw the allowed amounts based on the insurance companies, and I saw the EOBs, and I audited the payments. Okay. So from 18 years old, I was seeing the dollar flows in healthcare, and I'm going, this is crazy. They're paying 25% of what we build. How is this possible? So I'm already starting to unravel all of this. And now, fast forward, I get in, I have, and we can go into this further. I absolutely would love to tell you this story as well. But you get into the actual emotional, psychological effect of care, taking care of somebody, and the financial side of that. I get into direct primary care, and on the individual and sometimes employer level, I'm making an impact one by one by one by one, right? And I'm seeing it. And at least on the primary care needs, which by the way also are about 80-90% of your healthcare is at the primary care level. We can take care of so many needs without specialists.
Yeah.
I'm able to fix that portion. I feel like I've been able to fix that portion of somebody's care in my office, in my relationship with them, in this model. But when they left my office, when I sent them downstream, I sent them to the ER, I sent them to the surgeon, I sent them to the specialist, I sent them for imaging, I sent them for testing, whatever it may be. I realized once they're out of my hands, if I don't have a way of producing a price on the other side, or they're just subject to whatever it is, I'm literally subjecting them to the system, and my advocacy is gone. But not necessarily. So over time, I kept digging and digging and digging, going, there's got to be better ways, better ways, better ways. And sure enough, there are. There's better ways. And so several years ago, I made the choice to dive even deeper into health benefits. So I'm like, okay, I feel like direct primary care solved one half of this puzzle, but the other half, there's fixes, but they're not all solved yet. And so what I realized, and thank goodness there's many pioneers that came ahead of me. So this isn't all, my ideas. It was just me digging deep and finding out who's doing it right, where are they doing it right, how are they doing it right, how do I do it right, how can I play a part in this? And I realized, okay, this is cool on the individual level, this direct fashion of care, but this exists in group levels too, specifically in employers. And so I've had the privilege now of working with a bunch of employers. Not all of them are in those direct relationships, but many of them are. And there's something called a direct contract. What is a direct contract? Think of it almost like the anti-network contract.
Yeah. Okay. You're doing it directly with me outside of all these people.
Yeah. And just like I have a direct contract between patient and doctor in direct primary care, the same thing exists in health plans. So a health plan, employer sponsored health plan, again, we're taking monies out of their paycheck, we're putting monies as contributions into the health plan, and we're going to pay claims from that pool of money. And the real insurance is actually on the group, not the individual. We're actually paying claims based on those contributions. And what happens then is, okay, sure, we can use networks, we can use their discounts if they're okay. But guess what else we can do? We can go directly to the providers. So now we have direct contracts with surgeons, and we have direct contracts with surgery centers. We have direct contracts with health systems. And these contracts look far better than the PPO contracts.
Mm-hmm.
And guess who wins?
The patient.
Employer, employee, and providers, the health systems. We all win, but what did we do? We extracted an unnecessary third party. Again, I said 90% of it's done locally.
Yeah.
So if we can do 90% of our care and we can do it in a direct fashion, why would we send our money outside this community for them to reprice those services? And we don't have to.
So it makes you want to say, okay, that I want to. If I need something done, I would rather go down to the surgery center and set it up than go down to a hospital.
Perhaps.
But I mean, the doctor would probably have to do that. But like,
Sure.
that would be a better deal than going to the hospital because the hospital say, well, what does your insurance say? What can it do? You go to I mean, I don't even remember. It was like just using the room cost so much money. Then using this room it costs so much, and having the nurse aide there costs so much money. Or you could go to the surgery center for probably half the price. Well, the way you're talking, maybe 100% less.
It's all variable. I mean, those
Really?
prices
Yeah.
between facilities are highly variable, but we've had really good success even in the larger health systems doing direct contract negotiations. Those negotiations that the networks are doing, sure, they keep happening, but we don't focus on a percentage discount.
I wonder how much Blue Cross. I wonder how much Blue Cross made profit after paying employees.
I have no clue.
I'm gonna look it up real
But
quick.
you realize Blue Cross is 33 different companies all within Blue Cross Blue Shield of America. It's an association, so there's a lot of Blue Crosses out there, and they go by a lot of different names.
27 million, 1.2 billion in Michigan. Michigan's so poor.
I don't know.
How are they making that much money off the poor people of Michigan? Um, let's see, Oklahoma. How much is AI changing the paying game? Do you utilize it at all? Like,
So, of course, we're not coding for payment or billing for payment. I use AI a lot, actually, but predominantly what I use it for is to help me transcribe my records so that my communication is really clear and complete. Um, I actually have a major concern about AI being used in the billing side of healthcare because now to the health systems, this isn't a bad thing. To me, it concerns me a little bit. But using AI to essentially scrub the notes and help bolster the record from the standpoint of what can be billed. There's AI companies that market to me on LinkedIn and otherwise routinely that they don't understand I'm doing direct care or they wouldn't be trying to market to me.
yeah.
But routinely saying we'll increase your revenues by 30%. Why? Because there's more codes that they can bill. They're scrubbing the data, scrubbing the
So
coding.
they're using it to
Enhance billing.
yeah, yeah. Oh my goodness. Because right now it says, um, I guess Oklahoma's in a bigger network, right?
Yeah, we have
With
6 states involved.
yeah, yeah.
Healthcare
That's what I'm
service
seeing right
providers.
here. 61 billion with an operating income of 1.8,
Mm-hmm.
and a third of that's fraud.
Potentially estimated.
Yeah, estimated. Yeah.
That's on the whole of healthcare.
That's sickening. And there's no way. I mean, I guess the only way you could do it is if, and I believe in capital, it's very hard. Like, so what would you do? Like, you would have to have somebody literally dictate and regulate the whole thing, which then I think would doctors stop being doctors because they'd be like, there's no money in it. Um,
Here's the thing. I mean, clinicians on average across the system of healthcare make about 21 cents on the dollar. The other 79% of healthcare is everything else. So it's the providers are not the problem, as far as I'm concerned. And again, I'm very much with you from a capitalistic perspective, a free market system. I think if you can run a good business and you're providing value that in multiple ways, that your pay for the value that you're creating is worthy, right?
Mhm.
Great. But as my business partner and I, we say this all the time when we're working with prospective clients is our goal as a consultative approach to your business is for us to figure out what we can bring to the table that's valuable to you. And if in discussion we recognize that we don't have value to offer to you, then we shake hands, smile, and we move on
Mhm.
and pat you on the back and say, it's nice to meet you, right? It's fine. That's totally fine. But we come through so many different angles about how we think through things strategically. How, or do you have a strategy? All these various things we're going to bring to the table and say, what is it that would be helpful to you? You define what value we can bring to you, and we'll help you define that. But if we don't have value to bring, we don't belong here.
Right.
And the other thing is, as we vet our partners or vet our solutions, our vendors that we work with for health plans, et cetera, if through our conversations with those folks, and trust me, this has happened like somewhat frequently, unfortunately, but through conversations, there's a question that's asked or a question that's answered. There's a piece of information that comes up, and we recognize we don't feel like this person's heart is in the right place.
Yeah.
They just revealed to us how their revenue model works, and we're not okay with it. We don't work with them. So, in
So
certain ways, we are trying to maintain our integrity through our partnerships with people, and we vet them closely because there are some unnecessary parties in healthcare.
again,
You've got to be bringing
I'm
value. If you don't
why
bring
why
value,
why would someone not come to you over someone else? Like what would for
primary
care.
care.
Yeah. What would is there?
Cost. It's still a barrier to some.
Yeah, but
Is cost.
is there a benefit for them to go the other route?
If
There really isn't a benefit, is
if
there?
they're covered under a health plan that is a better financial deal for them to go another route, absolutely.
Like an employer type.
Sure. Or they've got, uh, $20 copay and they go to the doctor once a year and they really don't want to spend that much on primary care. I get that. I mean, there's plenty of that. But in many cases, yeah, most people when they come in, and I had a great story of a guy, honestly, at the beginning of my practice was kind of upset, vocal about the change I was making. And, on some levels, I was hurt personally because I was like, thought this was a really good relationship, and I think it was. But he was just really offended at the idea that I was turning against the typical system and the thing that he had paid so much for, this insurance product, was not valid in the way that I was practicing medicine, and he took it personally. And it bothered me, but not, there's nothing I can do about that, right? It bothered me, but fast forward, he's been through 3 other doctors in the last 6 years and finally just said, forget it. Whatever. I don't care. I'm mad. I don't want to pay this money, but I'm going to pay it. Within 3 months, he comes up to me, actually in public, shakes my hand. He said, just want to let you know I was wrong. I was like, about what do you mean? Wrong about what? And he said, about this thing you've done. I was like, okay. And he's like, well, he actually established with another provider in our office, and he said, I've been there 3 times in the last 3 months, and I've probably taken care of myself and my health 10 times as much as I did in the last 6 years. And your partner discovered something in my health that the last three had not, and probably saved my life. And I think it's because he had time to get to know me and time to ask questions and saw me a month later and a month later. And he's like, I just want to let you know this is pretty cool. Like, I didn't understand it to begin with, but now that I've been here,
Well, it's a educating yourself kind of thing. Because I remember this stuff is I've known there's been a problem, but I mean I'm gonna have to do more research and read more about it. But it's like it makes me feel so dirty, like that's even happening. And so coming to you, I don't even know how full you are. You like super full? Yeah.
yeah, personally, yes.
Okay.
Yeah.
Never mind, everybody. I was just gonna say, here's his phone number. Give him a call, but no, let's not do that.
No, we have plenty of availability for new patients.
Really?
Yeah, I mean, I do wear multiple hats between administrating my own practice, seeing my own patients, and like I said, doing health benefits. Uh, I like being busy, but I like being engaged mentally, and so I stay pretty well hooked up. Um, but my partners continue to grow their practice, and so yeah, I do my best to get people in within that week, if not the same day or next day, for new patients, which is not normal.
Well, we didn't even know this. Well, I didn't know this until today. My wife, where she works, she was like, I think I can go to him for like $20. That's it.
Mm-hmm.
Why are we carrying all this other stuff that we're carrying?
No, I'm curious.
Well, I'll tell you when we're off camera because what if I'm wrong?
What if you're wrong?
Yeah, it's a yeah. But they just saw that. What was I thinking? I was thinking the microphone was like never mind. This is stupid.
It's okay.
So yeah, she was just telling me about it. Like she's like, wait, that's who's coming in. Like it was kind of weird. You coming in today was a weird thing because it was on kind of a someone was like, Ryan, you'd be really interested in this guy, which he was right. Um, but then when my mom was like, yeah, Grandpa saved your life, and then my wife's like, yeah, I think we can actually go to him because of my employer, and I was like, wait a minute, then what are we paying for all this stuff? Like, I don't. Why are we paying for all this extra? So the truth is, if we paid you directly. And we could, now, I could be wrong when I said we could get a different insurance.
It opens up the opportunities to choose an insurance product that complements what you already have in place with primary care.
Right. And it probably wouldn't cost that much different.
Probably not. In many cases, what we've seen is individuals and families, and sometimes even employees, under an employer-sponsored plan, if they have multiple plan options, many times they will choose a higher deductible plan, something that is, of course, with a higher deductible has less of a premium cost because they're doing so many things under the umbrella of primary care.
Yeah, they don't have.
And then, if they exit our office, we actually help them find the place to go that's not going to hurt them financially. And so, this is even, this example is a couple of years old, but even one of my colleagues, her child needed to have tubes in her ear. They're on a high deductible plan. I don't remember, $5,000 or $6,000 deductible, and she had a few options. The option she took was to pay cash, $2,800, all in, surgery center, surgeon, and anesthesiology.
Because she went outside of the.
It didn't apply toward the deductible,
Mm-hmm.
but she had like 5 or 6 weeks.
Who cares?
5 or 6 weeks left on the plan year, and it's like, I'm going to save myself $3,200 is what I'm going to do, or in this case, $2,200.
So I get a high deductible in case I got cancer or something, but then outside of that, it'd probably be cheaper than paying your deductible, certainly if you don't go 5 times a year.
Yeah. Yeah, and being on the benefits side as well, one of the things, and it wasn't new to me, but it's definitely something I've taken more heart in, is everybody's situation is a little different, right? And as I mentioned, taking a consultative approach to benefits is saying, where are we at? Like, help me understand kind of where your needs are. Help me understand whether that's to the employer as a group, or if it's the employee or individual, saying, what are your needs? And by the way, I'm a licensed insurance agent. I can actually counsel you about this, which is crazy.
Yeah.
Here I can counsel you about your health and what you can do to improve your health. But I'm also a licensed insurance agent. I understand the rules of the game, and I don't mind playing that part for you as well.
Yeah.
Because I'm not going to bill insurance for the care I provide to you, but I can sell you an insurance that protects you when you need it and when I can't.
It's nice to know that there's people out there who actually genuinely care for the patient, because there comes a time when you start to think you're just a number, or when you call and you're an inconvenience. Not calling after hours, just in general. Like, I need to set up an appointment, and you hear them, well, it's going to be really busy. Can you come on this day? Sure, I'll come on that. Whatever I need. Then you go in, and it's like then you're kind of down to. It's a different conversation. I don't want to sell people out. I love all people, and I think people have their, that they might have reasons for the way they do things. Example, I've been dished out so much medication over the past 5 years. It has been one thing after another, trying this, trying that, trying this, and it was really for depression. I was struggling hard, and then being a pastor, it's really hard. And also, when you admit that as a pastor, people say, well, there must be something wrong with you. It's not your gifting, or whatever. That's not necessarily the case. But what was happening was I was getting so much medication all the time. Here's the next one. It's not working. We'll try this one. If that's not working, let's try this one. What happened was things were getting worse. I go to a functional doctor, pay $800 one time, and he did a blood work, a type of, or gene work, like to look at my genes. Not once was that ever offered. Well, when I asked about, because my wife was looking it up herself, because she was like, something's wrong with my husband. We asked the doctor, well, your insurance won't cover that, and it's not really necessary. This is what you need to do. I'm like, but it's not working. Well, we'll just try the next one. I remember there's like 30 of these. It takes about, you know, 4 to 5 weeks to see if it's really working. And if it's not, we'll try the next one. You know how long that will take before? And they're okay with that. The insurance was okay with me paying for all that, which is weird. But this one $800 payment, I go to him and he pulls out a supplement, finds out it's a gene mutation. 1 week later, I'm feeling better, like I've never felt before. You know how much that cost me? $30 a month. Mm-hmm. And most of that's the shipping. And I'm just like, why? Why is that so much different? Now, I know functional medicine is different. It's not the same. It's like a different approach. But why would they not allow them to do what needed to be done? Like we could go in and show the doctor, this is what our research is saying. And they go, yeah, but your insurance won't cover that. We can't do it.
Yeah. So here's where I get defensive of the health system, the hospitals, the doctors. Here's what I will say: administrators, even people within insurance, by far and away, what I would tell you is healthcare is made up of really, really, really good, well intentioned people. Mm-hmm. I wholeheartedly believe that. Okay. Are there bad players? Yeah, everywhere in the world there are. But healthcare is made up of really, really good players. Okay. The system itself is broken. I believe that. But they're good players. And so, share things like that. And my thought is, what does this look like on the end of the doctor's conversation? Because he's sitting around or she's sitting around the doctor's lounge or at lunch break talking to a colleague and going, I've been trying to take care of Mr. Nelson here for, gosh, it seems like 6 months. Nothing I do works. I don't know what else to do. I can't get this done because insurance won't cover that. So I'm kind of left with like, I guess we'll just try. Like, we'll try. I mean, surely we'll find something that works. It's not for lack of trying or lack of care, but we know what the problem is. I've got 3 people in front of you and 3 people behind you. So, like, I'll give you another 5 or 10 minutes. We'll talk about this. Oh, this didn't work. Okay, well, let's stop that. Let's try something else. Okay. Does it mean they were poorly intentioned or don't care about your outcomes or really only care about the billing? No, these are really good people practicing in an everyday world for them. And it's really easy. I actually read an article about this recently, and it really kind of helped me understand not just myself as a physician, but just kind of in the broader sense of um, being in situations where we're emotionally damaged or emotionally hurt. And many people, when they get hurt or get in high stress or high conflict, they withdraw. A lot of people do.
Yeah.
They emotionally withdraw because to get emotionally involved even more hurts too much, causes too much distress. And so there's this emotional withdrawal. And unfortunately, as I read this, I just thought, man, this affects so many of my colleagues. And here's how it works. We pour ourselves into trying to get the answer, and it doesn't work. We pour ourselves into trying to get the answer again, and it doesn't work. And we pour ourselves into it again, and it doesn't work. And the frustration builds. And the fear of not coming to a solution or the fear of failure being on this side of healthcare is a real thing. We're real human beings who care a lot. So those failures for you as a patient become our failures as a physician. And the more times we fail, the more we withdraw. In some cases, we start to emotionally withdraw. And this is when I start hearing patients talk about how I just don't feel like my doctor cares anymore. Like, I mean, they were great when we first started. I just don't feel like they care anymore. And it may be that they've cared so much that it's hurt too much and they've emotionally withdrawn.
That could be true.
I think it is true in many cases.
Yeah.
And it's on the individual level. Now, it's on the individual level up to a certain point until you see a physician who's truly just morally injured and burned out, and they're just emotionally withdrawn from the whole thing. Everything's become transactional. Everything's become more superficial. once good relationships are now strained, and one strained relationship leads to the next, and they see themselves crumbling internally as they're trying to practice. And the trouble is, just like you said, for a pastor who's going through depressed moods, and who do you reach out to because people are going to be critical of you? How do I, as a physician who is probably at the upper, uh, toward the upper marks in terms of personal income, ever tell somebody around me that I have it bad?
Yeah. Yeah, it's kind of hard to do.
Who do I turn to?
Yeah.
Who could I say that to?
It's hard.
Sure couldn't say it to a patient.
No, that'd be hard.
And if I complain to the administrators, then I become the problem.
Yeah.
The problem's no longer the problem. I'm the problem because I'm speaking out. And I'm causing tension.
Again, that's why I've not said names, because I have grace in that area. Like, I actually have grace, because I'm like, there's things I probably don't know. Um, there is there's just, and I know there's probably bad players, and that's probably the case. Like my wife, for instance, she was feeling so much pain. She did my wife's a researcher. Like, she should have been a doctor. I'm not gonna. We're like walking science experiments around here. But she I was in so much pain, so much pain. So she goes to the gynecologist and says, "Listen, I'm hurting so bad." She goes, "I think it's endometriosis." And he like grabbed her somewhere and said, "Well, if you had endometriosis, you'd jump off this table. You don't have it. Something else." Gave her these medicine over time. We just gave up. We didn't know what to do. I mean, she was literally falling on the ground in pain, thinking it was a potassium issue. Like, because we went to the ER and they were like, she's low in potassium. So that was what they thought. Well, this is what it is. My wife, with her just research, kept telling him it's endometriosis. They kept telling her, no, it's not. No, it's not. And again, we heard insurance won't cover it for us to look to see. We have to do all of these other things 1st. Mm-hmm. We just skipped it, went to the city, paid someone outright, just paid cash. Don't worry about the insurance. Went in, cut her open, endometriosis covering all over the place. I mean, it was so bad that they had to cut almost everything out. And the whole time she was being told that she was crazy. Like, the words out of their mouth was, if you think that's working, then we'll just let you believe it's working, but that's not what it is. That's what they told us. Like, and I was like, I'm trying so bad. I don't know if that's just a bad player. I don't know, but I'm like, I am so upset because my wife, and then she did the same thing for me. She went in and said, I believe that it's more than this. He needs to have this test done. I'm a doctor. You're a housewife. I know what's best. Is kind of the conversation we got. WebMD is not where my wife's not looking on WebMD. All right, like, that's what. Stay off the internet is what they keep telling me. Stay off the internet. It's just there to. She was right on both accounts, like 100% right. You know, I feel like there is where we come across as patients is we're just numbers and not real people, and we are the next in line. There's 3 people in front of you, 3 people behind you. We need to get you through. And yeah, we care what you have to say, but we don't care enough to take it in consideration if the insurance company doesn't take it. Like, I don't know why it wasn't just, why don't you just pay for it? I'll do it if you pay for it. I would have paid for it. But it was, we can't do it because your insurance. Well, what if I want to pay for it? Well, we can't do it because of your insurance. We have to do this, this, and this, and this. Is that true? Or is that just they don't think we'd actually pay for it?
In certain cases, but they probably just don't offer to let you pay for it most times.
Right, yeah.
Because it's usually not a feasible thing for people.
Yeah, I mean, it was like $6,000. But I was like, you know what? My wife is passing out. Like, I'm willing to pay $6,000. Like, certainly if my wife's not stupid, like, and that was the other. It blew my mind. It was I call it almost like hubris. Like, they were looking at it, I was like, you don't know what you're talking about. I went to school. I've got the degrees. I've done all of this. That it's said it was a placebo effect, is what my wife was having.
Hmm.
And she literally had, they said, one of the worst cases they'd ever seen. And they were telling her, you don't have endometriosis.
Hmm.
There's no way of knowing unless we cut you open, and your insurance company won't let you do it based on your symptoms.
Yeah, it's inexplainable.
Okay, so
Huh? Yeah.
I want you to know, like, that just tell the world that really happens, because I think people think I'm crazy. Like, they're like, there's no way that they would have done that. And I'm like, no, she went in with documentation saying, I'm feeling this, this, and this. I went on another thing, talked to ladies who had the same problem, ended up having endometriosis. I know this is what it is. And they were like, that's not what it is. This went on for probably 3 years.
Wow.
And then we went to the city and just paid outright. And they were like, yeah, that was straight up the worst case of endometriosis we've ever seen.
Yeah.
And I don't want to call the guy because I actually know him. And we're like, I was part of a church thing with this person. So it's like hard to just be like,
Yeah.
you know, but it's like,
No, I get that, but I think what you're
am I missing?
highlighting that's so common is that whether it's a story like that or a story of I'm waiting in the waiting room for an hour and a half and I got 5 minutes with them. There's so many different anecdotal stories about the experience of healthcare, and I talk about this when we think about direct primary care. We call it DPC. So when I think about DPC, we're sort of redefining the healthcare experience. Really, is what we're doing. And we're redefining it in the ways that consumers care about. They care about being able to get a hold of you. They care that you've taken the time. They care that you've considered their financial impact. You've considered all these various things. There's various different ways to measure the experience of healthcare. But unfortunately, most of the ways that it's measured is not through an experience of the patient, but through the outcomes measures or quality metrics, which to my colleagues, they hear those terms and they're like, ugh,
Yeah.
what do you mean quality metrics, value basis, all these different things? But what matters to a patient versus what matters to a payer are very different things, except in direct primary care. Think about that.
Yeah.
If it matters to the patient, that is the payer.
Yeah, it matters to you.
It
Yeah.
matters.
It's
My
more, it's
accountability.
actually more capitalistic.
It is absolutely aligning my accountability with you. And so we are redefining the healthcare experience for patients, one patient at a time, one group at a time. And those experiences that you had, we can't take all those away. And I'm glad you didn't mention names, but I can tell you, you could almost fit any name into that conversation at some point in our careers, our days, our weeks, our months of being physicians. We've had some conversation where we didn't see something coming or didn't recognize something.
Well, we're human beings.
We are. But it's the experience of saying, like, I just need you to, like, dig with me a bit. I need you to advocate for me a bit. And
And it's okay to tell me that you really don't know. Like, I'm okay with that. Like, I don't look down upon, so I do not expect a primary care physician to know everything about everything. Like that is asking a lot. That's asking them to be God. You know, and it's like they can't do that.
Yeah.
But I don't like it when they say, well, we'll try this. Like, do you know or do you not know? And it's okay if you say, I just don't know.
Three most important words in medicine. You have to learn them early,
I'm
and
good with that.
they're hardest words to say. Because think about this. I mean, okay, think about our perspective for a minute. Okay, we spent on average 4 years trying to get into medical school. We spend 4 years in medical school at an average debt of about $300,000 today. Then we spend an additional minimum 3 years in residency training. That's just for primary care. If you go into a surgical specialty, it's 5 years or more. Okay. By the time you come out and someone has scheduled an appointment, taken time off work, traveled an hour and a half, you name it, whatever they've done to get there, paid their copay, waited in your waiting room, filled out all the paperwork, explained everything that they could in their best way possible to tell you what they think is wrong or here's my concerns. That's a long build up to be able to say, I don't know. When the highest of expectation is on you to know, to have an answer, to have a solution,
I
to
have
have
a
a next
graceful
step.
heart because I could just hear them say, I don't know, but you know what? I'll do my best to find out. And I'm like,
And
awesome.
that's I mean that's my philosophy. I learned that very early on. I've also been very quick to say I was wrong when I've done those things. I had this. You've actually hit on a couple things that I had conversations about this morning. One was about uh, for your own personal health, in that um, if I'm to admit that I've got a mental health concern, then the suggestion is that perhaps I have a spiritual health concern, that I'm not in a place that I should be leading other people spiritually if I have a mental health that's not at its highest level. I literally told a patient this morning, your mental health and your spiritual health cannot be separate, but they are two different things.
Yeah.
Because I will tell you, my greatest spiritual health has been at many times my worst mental health. It's when I needed God so deeply that I had to dig spiritually, but I was at my worst mental health.
Yeah.
But it's also why, in those moments, that's where my faith is deepened, is when I'm hurting so badly, when I'm crying to God, going, why? I don't understand this. Why am I having to deal with this? Questioning everything around you. And so I get that. And whether you're in ministry or you're in medicine or you're in leadership somewhere, in many cases, for us to turn and ask for help, but also to trust that the help is going to be there, is really, really challenging.
Mm-hmm.
For me to say these things, even in front of colleagues, to talk about the system in the way that I do, depending on where I'm at, I'm actually fairly guarded.
Yeah.
Because the one thing I don't want to portray is that I have some critical eye towards my colleagues who are doing the best in a broken system.
And I'm not.
I know you're
Yeah.
not,
Hey, I'm glad that you said it because that's not what I'm trying to do. Yeah.
and I know you're
Yeah.
not, but I'm just clarifying.
Mm-hmm.
This isn't a criticism of the people who've dedicated their lives to help other people, but it is a criticism of the system that has drained us while trying to do so,
Mm-hmm.
and the methods in which it's been drained. How we've taken what was meant to be a relationship and created a transaction out of it.
Mm-hmm.
Relationships aren't transactional. You can have transactions within a relationship, but the relationships themselves are not transactional. And that's what third parties have done in healthcare.
Well, I kept you here way longer than I said.
It's okay.
I said I'll keep you here an hour, and it's been almost. It's an hour and 50 minutes.
I want to go back to something you brought up in the beginning, since you mentioned you knew my grandparents. It's interesting. My grandparents had been. My grandfather was a Nazarene minister in multiple smaller towns in Kansas. You mentioned Syracuse. I still have family in Syracuse. Um, and then he'd been out in Sedona for about 20 years, really, as Sedona blossomed into the community that it is in Arizona. Um, Interesting story there. He was actually given a piece of land on the creek right in the middle of Sedona in 1980.
Wow.
Built his own home, lived there 20 years. And when I proposed to my wife, Andrea, I proposed at Red Rock Crossing, the place that I went to as a child to play. And after that, we drove to his old home, knocked on the door, and asked the people that bought his home if we could go out and take a picture on the deck overlooking the valley. And we did, and that's how I shared with my family that I'm getting married, which was really, really cool. But yeah, Sedona till 2000. Then he moved to Woodward for about 10 years. I had finished up high school there, played baseball there, and then they moved on to Enid. And my grandfather, we would for all of his all the positive things he would do, we'd be like, oh my goodness, he was so helpful that he got hurt helping people. He would just get himself into situations where all he wanted to do was help, and get abused in the process at times.
Yeah, he's a pastor.
And he was what?
He's a pastor. That's what
Yeah,
happens.
yeah, and he could not give that up. And kind of an interesting story toward the end of his life. And when his health started to fail, he was 89 years old, um, and was getting to the place where this is during COVID. This is 2021 during COVID. and really struggling. And we were recognizing pretty quickly that his needs were going to surpass what we could provide at home health through home health. And he was fearful of ending up in the hospital and not having family near him during COVID and all these various things. Well, being the physician in the family, all four of his kids were a little nervous or uh, just simply wouldn't talk to him about, hey, Dad, we need to consider end of life discussions and hospice and things like that. Well, I'd been a hospice medical director, still am, but had been a hospice medical director for years. And so I get the call that, we really need to talk to him about this. I'm like, okay,
We really want you to talk to him.
this is my duty. What I didn't tell you was that 2 months before this, I had agreed to speak at a continuing medical education conference. And the subject was, do I have to talk about this? Conversations with your patients about death and dying. Mm-hmm. I had literally just prepared this lecture over the subject that then became
your life.
My life.
Yeah, your personal life.
And I remember having that conversation with him, and it was actually somewhat simple and straightforward because it starts with someone who has needs. So that's where we are as patients or as physicians. I said, Grandpa, I know that you probably realize this, but there's a lot of things that you need and care that you need that we're struggling to provide. And we're going to have to get some more care for you. But it kind of depends on what you want. So what's most important to you? What are some non-negotiables that we have to think about? What's most important in your health and how we take care of you? And he said, I want to be at home. I said, okay. And I said, anything else? He said, I want Merle with me, his wife. He'd remarried after my grandmother passed. And I said, okay. You want to be at home and you want her to be with you. Okay. Anything else? He's like, no. I said, okay. We want to honor your wishes and we want to make sure that that's what you get, is to be at home and to have her by your side. And in order to do so, we need to bring extra help into the home. Is that okay? He said, yeah. I said, okay. We're going to have to transition to a different care service that's going to be able to provide those things that we can't provide today. Never used the word hospice, nothing like that. I just gave him the really basic terms of this is what you need. Here's how we meet your needs. Here's everything that they'll do for you. But here's the caveat, Grandpa. If you fall or if you cut yourself like you have a couple times, we're not going to the ER. Okay? We'll take care of you. We'll make sure you're not hurting. We'll make sure you have what you need. We're not going to the hospital. But I don't want you in the hospital because if you go to the hospital, chances are we're not all going to be there next to you. And that's important to you. And he's like, yeah, I don't want that. I said, okay. Wow. So that's it. It was a 60, 90-second conversation, transitioning him over to hospice for the next few weeks. And anyway, I tell people all the time in those conversations that we don't always get to choose. We don't get to choose how we die. We do get to choose how we live. And that's what he did. He chose how he wanted to live. And in a sense, he chose how he wanted to die, which was in the peace of his own home with his loved ones. And you think about that in the way that we honor people's autonomy, and that's lost a lot of times in the conversations with patients, in the conversations with loved ones, is that the most loving thing you can do is honor someone's wishes. But it's also the most loving thing to let those people around you know what your wishes are. Yeah. Kind of takes both sides. Yeah. But again, doing hospice work and working with people all these years, I can tell you those are the best situations when everybody understands. Doesn't even mean they agree, but as long as they understand this is the person's wishes and I'm honoring them. Yeah. It's tough to do.
Yeah, that's your grandpa must have been a good dude.
He was.
I see it the way you talk about him.
Yeah. No, he was. It's funny. He annoyed me in certain ways that are laughable at this point, but in many ways, I look and I think of the things that he did, and the way he saw people, and like you could never criticize the way he looked at people and his role in their lives. He almost took too big of a role in many cases. Um, but we had our moments. We had some
He married who?
fun times. Merle Black.
She has a son, correct?
Yeah.
He was a singer.
Yes, son-in-law.
My mother sang with him growing up, and they did something together at the Nazarene Church here in Enid. Um, that's when I met your dad, as I went there to watch her sing. I think it was here in the Enid Nazarene Church. I think your dad was there. He was
Grandpa or dad?
or grandpa. I meant grandpa. Yeah.
Yep.
That's
Funny
wild.
enough, my grandma, Joan, her maiden name is Nelson.
Wow.
And I have a baby due in 17 days whose middle name is going to be Nelson. After my dad's middle name is Nelson, my grandmother's maiden name is Nelson. Yeah.
What's first name going to be? Ryan. Don't do that to him. Don't do that to him. Yeah, this is awful.
Yeah.
Someone else. Yeah, never mind. Different time, different story.
Yeah.
Right. Thank you so much for being here. I really appreciate it. Maybe we can do a part two sometime down the road.
Yeah.
I know you got bigger stories to tell and things to share that are really quite interesting. But today we'll keep it at the 2 hour mark.
Sure. Yeah, no problem.
Thanks again.
No